Here on Game Changers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting ceimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count. Hey CE Impact subscribers, and welcome to the Game Changers Clinical Conversations podcast. I'm your host, Rachel Maynard, and I'm super excited about our discussion today. We're going to be talking about Alzheimer's disease, and about 7 million people in the US are living with this condition. And I think many of us may have had our own experiences with Alzheimer's and seen its impact either directly with our own friends or family members or when interacting with our patients or their caregivers. And there's currently no cure for Alzheimer's, but there are strategies we can suggest to help improve symptoms. But it's still very challenging to manage. And that's what I think interests people in any potential new treatment option where they're looking for something. And we want to better understand any potential options so that we can put it in perspective. And so today we're going to be looking at whether microdosing of lithium plays a role in managing Alzheimer's, because it's gotten some attention lately. And so we're going to be looking at whether there's any good evidence to support its use. And so I'm thrilled that our guest today can share her expertise in this area. And I'd now like to welcome Dr. Dawn Gerber to our discussion. So welcome, Dawn.
Thank you so much. Happy to be here.
Okay, great. And maybe you could share a little bit of background about yourself, your current role, and I think that might tie into why you're interested in this topic too.
Excellent. Yeah, happy to be here. So I'm Dr. Dawn Gerber. I'm a professor at Midwestern University in the lovely Arizona desert. And people may not realize this, but in Arizona, very similar to Florida, we have communities where you have to be 65 or 55 and above to live in those communities. And then even in those communities, a lot of the Phoenix and Tucson area are older adults. So I practiced for 17 and a half years in a primary care clinic in those cities. So working with geriatric patients, and so much of our population, because of the baby boomers, is geriatric by default. So worked a lot in the primary care setting with polypharmacy, and a lot of patients wanting to know, grandma's Alzheimer's medication isn't making any difference, or what can I do to prevent myself from Alzheimer's? So this is a topic that is near and dear to my heart.
Excellent. Well, very, very happy to have your perspective on this. And I'm sure you have a lot of, personal experiences that you can bring to this discussion. So just very thankful for your time and for you sharing your expertise with us today. Let's go ahead and get started and just get on the same page about what Alzheimer's is. So what causes it? What are the risk factors for it? Symptoms, and let's start there.
Sure. So definitely with the major risk factors, obviously connected with age. The older the patient gets, the more risk that there is for Alzheimer's. Although we do see a decline if patients in general, if they don't develop Alzheimer's by about 80 to 85, then that risk actually decreases. When it comes to the pathophysiology of Alzheimer's disease, the scientific community, we don't have this is absolutely, 100% what causes this disease. We talk a lot in science about how Alzheimer's disease is a diagnosis at postmortem. A lot of what we talk about is, and especially if you really look into the literature about this, it's a lot of highly probable Alzheimer's, likely, maybe, potentially. And so that is something that I think ties in nicely with this topic, and why there's probably a lot of frustration with patients of, when we're talking to patients in a medical term, we use words like probably, likely, and that's frustrating. I get that. As a patient, you want black and white, and unfortunately, this disease just isn't. And then especially since 2020, we've had the new MABs, the monoclonal antibodies that have made huge headlines and related to tau tangles, plaques, and then along with that, the ApoE allele formation, where increase being a high risk factor with ApoE4 puts you at high risk for Alzheimer's disease. And you may have heard of Chris Hemsworth getting tested and and
Oh,
that
yeah,
made,
right. Yeah.
made a splash too. So we also know that cardiovascular disease, sedentary lifestyle, unfortunately, lower levels of education are also associated with Alzheimer's disease as well. And then, unfortunately, because we don't really understand the true black and white nature, patients that you would just never guess can end up with Alzheimer's disease.
So, what are the most common? So it sounds like we don't have a good understanding of necessarily the pathophysiology. There is some proposed, theories, right? And you mentioned the plaques and the tangles. So maybe you could talk just a little bit more about that for our understanding here. And I think that would help explain how those newer MABs, like you said, are coming into the picture too.
Yeah, so it actually ties back to that post-mortem diagnosis is looking at the patient's brain and seeing these plaques and taus, and the fact that we see that patients who have been diagnosed pre-mortem with Alzheimer's disease or likely Alzheimer's
Hmm.
disease
Hmm. Hmm.
present with these. Um, Changes. We also have the cholinergic
Hmm. Hmm.
seesaw, and that's where some of our traditional medications, I should say, oral medications like donepezil and memantine, they come into play. And so there's a lot of discussion, but it's a little bit of a chicken and the egg. So do the tau and plaque, do they cause, or are they somehow correlated, but not a direct cause? And I think that ties into these newer medications, the MABs. We only have, I think, the longest research that's been published at this time is like 74, 75 months, right? We're
Okay.
not, and this is a disease of
Yeah.
years.
Right. Right.
And so we still are trying to figure out a little bit of chicken and the egg. If we remove these, does it reverse the damage that's already done, or does removing them just leave the patient kind of where they are at, or does it cause reversal?
Right.
Don't really know.
And I
So
think
I think we're going to see a lot in the future, but I think it also does this this kind of nebulous discussion also lends itself to patients wanting to take matters into their own
right.
hands and
Right.
trying to find answers that aren't out there, that are out there on the internet.
Yeah. And I guess to bring that home to some of the symptoms and um common issues that patients have, because maybe you can also clarify, there's Alzheimer's disease. Is that always dementia, or are they sort of different concepts, and or do they always happen together? Some of the symptoms and just the complications that patients have to manage on a daily basis. What does that look like?
Yeah, absolutely. So there's definitely, dementia is an umbrella term, right? And
Okay.
we
Yep.
use it for so many conditions. In fact, I was just having a conversation with an older adult yesterday, and they were like, "Oh, so I have the same thing as maybe another celebrity that's pretty famous that has um, temporal lobe dementia versus the famous comedian who had Lewy body dementia, right?"
Hmm.
And those
Hmm.
two, compared to Alzheimer's disease, are all very different in their symptoms
Hmm.
and their pathology and what the speed of the condition is as well. But if we're just talking about general Alzheimer's, it's memory loss plus, is what I explain to patients. So if you look at the diagnostic criteria, it's memory loss plus maybe speech difficulty, executive function difficulty. So it's not just memory loss. There has to be that plus. Something else is going on that impairs the patient's ability. And I think most of us recognize that a little bit of memory loss is somewhat viewed as common, but when it starts impacting ability to, I always use the example of make a grocery list, go to the grocery store, buy the groceries you need, come home, that's where we see the impact of Alzheimer's disease. I had an uncle who ended up on the highway because he went to the grocery store, forgot where he parked, and then just started walking
Oh
and ended up in
no.
walking along the highway.
Yeah.
I'm from a small community in Iowa, and thankfully, somebody called my father and was like, "Hey, I saw your uncle walking on
Wow.
the road."
Yeah.
Right? So that's where a lot of our, people don't die from Alzheimer's disease. They die from accidents,
Yeah.
just like what happened to my great uncle. They die from malnutrition, dehydration, because they forget to eat
Right.
and
Right.
drink. They die from infections. Pneumonia is really high. So people don't necessarily die from Alzheimer's, but they die from the consequences of what that causes.
Okay. All right. So you talked about how you gave a very good example of how this can directly impact patients' lives and be a very devastating sort of illness. So, to your point earlier about people looking for something to help manage this condition, I think that ties into why we're starting to see, all kinds of things people might be interested in trying for Alzheimer's to help manage those symptoms. And that brings us to our discussion today, which is microdosing of lithium for Alzheimer's. And that's gotten a little bit of buzz lately. Some headlines have come out about this. So let's just first think about lithium, traditional use of lithium before we get into the microdosing side of things, and just get a quick overview of lithium and its traditional role, and then maybe how that has either led to some of its interest for Alzheimer's or where that sort of interest is coming from.
Sure. So, current guidelines for Alzheimer's disease and current prescription FDA approved medications, there's nothing for prevention, and we know that's a big area. So the history of microdosing, or even just looking at the history of lithium, and there's a great publication that was published just recently, actually, in 2025 in the Journal of Pharmaceuticals. Um, did a great job of kind of outlining this. And so the history is really kind of looking at some of those population models
Mm,
and observation, which we know from current discussions with, vaccines and things like that, is that causation is not or that correlation is
hmm
not causation. And
hmm
so really where lithium kind of got its start with maybe some discussion about Alzheimer's disease is population studies looking at that populations that lived in areas and consumed water with, because lithium's naturally occurring, that when they drank water that had very tiny concentrations of lithium, that these populations seem to have lower incidence of Alzheimer's disease compared to populations that didn't live or in areas where lithium was naturally occurring and they were exposed to it via their environment or water. And so, once again, causation, correlation,
Right, right.
hard to say there. Another area where this has kind of come into play is that very early, going back all the way to the very early 1970s, patients being treated with lithium for bipolar disease seem to have less incidence of Alzheimer's disease as well. And so that is between the two of those, that's really, I think, where the conversation started. And if you look at lithium's traditional role, so it's a first line mood stabilizer for acute mania, and then, if appropriate, maintenance in bipolar disorder. It's also used sometimes adjunct for treatment-resistant depression because it has some anti-suicidal benefits as well. It is involved with neurotransmitters. There's some very preliminary discussion about how does it affect possible plaques and taus, right? Which
hmm
very
hmm
similar to that pathology that's being explored for Alzheimer's disease. But really, that is in very early, you know, stages. We're talking cellular models, we're talking mice models, things like that. So I can see where there'd be an interest in, hey, we're seeing this with this condition, let's investigate it for another. But unfortunately, lithium is not the first line treatment for patients who are older adults. And I'm defining that as 55, depending on your disease states, or 65 kind of in general.
Mm-hmm.
And so we don't use lithium because of the very high risk of that narrow therapeutic index that lithium
Mm-hmm.
has.
Mm-hmm.
I did not work with I worked with a general geriatric population, but I just did not see very much lithium being used, even for patients with bipolar, because of the risks associated with lithium, even in treating bipolar.
Interesting. Okay. So a few things you said. First of all, I find it really fascinating that some of the interest in lithium for Alzheimer's was generated by, as you say, like these epidemiological sort of studies where they're seeing, okay, there's trace lithium in the water and we're seeing lower rates of dementia. So maybe there's some link between lithium and dementia and reducing dementia risk. That's a very interesting sort of concept. And those sorts of things are always, what may generate future research and evidence that then does support some broader role. So very interesting about how that came about. And then also, how you're saying that even patients who have been using lithium for bipolar, traditionally, there's been some link there as well, it sounds like, so that some of those patients may have had lower rates of dementia, but for using lithium for a different condition. Okay,
Yes,
so
yes.
that's all very interesting. And then also, I think
Observational data. So that's really important,
observational.
right? Not
Yes,
head to head, not
right.
comparison. It's observational data.
Right, right. So not saying, okay, let's see if lithium is an effective treatment for Alzheimer's, that randomized controlled trial sort of format. Okay. So
None of that
that
out there.
but then the contrast that you also shared is really good perspective. The fact that even regardless of the role of lithium, potential role in Alzheimer's, you tend to steer away from lithium in general in older adults because of the risks that you mentioned, the narrow therapeutic index, risk of interactions, potential side effects. So regardless of any potential benefit, it's generally a drug you tend to avoid otherwise. Is that
Correct.
right? Yeah.
Yeah, especially in Arizona. We
Right.
already have our older adults that are at risk for dehydration during our
Right.
very intense summers. And dehydration is one of the number one risk factors for lithium toxicity leading to death. And so, we worry about dehydration in older adults in general. Although my hope is with all these, cups running around in the millennial generation, maybe we won't see the dehydration risk that we see in the baby boomer generation. So maybe that, maybe all these, fancy cups
That's right.
will help with that. But yeah, we do worry about the long-term, right? It's risk and benefits. So
Always. Yeah.
even patients who are treated with lithium for bipolar, the long-term exposure to lithium, even when it's within that narrow therapeutic window, there are still risks. And it doesn't even, I have patients who tell me like, oh, well, I haven't been on this very long, or I don't take it very often, just
Mm-hmm.
talking about medications in general,
Yeah.
right?
Yeah.
But if a patient becomes, just a one time, just because of situation, dehydrated, and they're taking lithium, that can skyrocket their
hmm
lithium
hmm
levels. They take, I wish I could get NSAIDs, kind of that third category, in pharmacy where you have to
hmm
ask for it, and there's some
hmm
screening
hmm
questions,
hmm
because, just even NSAIDs can increase that risk of toxicity with lithium. So even if the patient is monitored, they're within that narrow therapeutic window, and they, roll an ankle doing pickleball with the grandkids, they go to the OTC aisle and they don't have to speak to anyone to purchase,
hmm
ibuprofen or naproxen, medications in
hmm
that
hmm
category. And now suddenly a patient who is closely monitored by their physician can do something total, and no one thinks, oh, well, this medication over the counter, that's going to affect my bipolar medication. Patients don't have that
Yeah.
connection. So even, a couple of doses of NSAIDs because you
Yeah.
rolled your ankle playing pickleball with the grandkids can suddenly lead to an acute emergency situation with closely monitored lithium.
Yeah. Yeah. And it's I love that example because it is one of these things that just it can tip the balance for whatever reason. You can tip that balance, and it could be dehydration from working out in the yard or having a bout of
Yes,
diarrhea or whatever. There's all kinds of
yes.
things that all these situations can come together and create this sort of perfect storm that causes an issue. So I think that's a really important point. But I think that's probably where some of the interest in microdosing is coming from, perhaps, because that, in theory, is using a lower dose. So maybe you can speak a little bit more about what that actually means and what this microdosing concept is.
So it really is a true concept, and that there is no standardized. We have a we have a lot of studies
Mhm.
looking at this, and there is not a standardized, this is the therapeutic window in humans that we are looking at. In fact, one of the very, very few studies that actually did look at this in humans, unfortunately, was a 10 weeks. It was only 10 week study. Um, and it was really looking at kind of what I call surrogate markers. So
Hmm.
BDNF, serum concentration. And so it it was looking at zero point 0.5 to zero point 0.8 millimoles. So once again, kind of the dosing thing, right? We dose it based on serum levels
Hmm. Hmm.
versus being able to
Right,
say,
right, right.
1 microgram is what you need. And so when you look at the actual doses that are being used, when you're looking at those, you know, scattergrams, they're all over the place because it's
Okay,
based on serum levels that are being monitored through blood
okay,
work. And I think that
okay.
makes it hard to also come with a, what dose is effective,
Hmm.
what dose is being studied, because that's not even how we dose,
Okay,
right?
okay.
Let me find in my research, I did have, so mi microdosing in the research, when they look at what's the kind of that average dose for those people that are trying to get that serum level, keep in mind, these are very tiny, tiny. That study that I just referenced was 27 people.
Yeah, yeah.
um, looks about 300 micrograms per day of lithium carbonate or lithium orate. That was roughly, but once again, we're not talking thousands of
Right,
people,
right,
and we're
right.
looking at a medication that really does need to be individualized.
Yeah,
And this is about 1/3 to 1/5 of the average lithium dose for like bipolar. But once again, even for bipolar, you treat to the serum level, not
right,
the dose.
right. So, bottom line is the theory of microdosing would be to use a lower dose to help minimize any of those potential side effects or interaction concerns. But we have no good data to say what that microdose, even if we wanted to use a smaller dose, should be, or even what salt of lithium to use, because there are multiple salts, and we don't know which one would be preferred either for that reason. Okay. Okay.
Absolutely, absolutely. And most of the research that, you talk about making a splash in the press, they are, I love this title, Lithium and Neuroprotection. And that's all that you hear, but then when
Mhm.
get into it, it's cell models and it's mice models, and
Mhm.
none of the studies were looking at what I call clinical outcomes, right?
Mhm. Right,
Did
right,
we delay patients from going into assisted care? Did we prevent emergency room visits? Did we prevent patients from uh, economics? So much of patients with Alzheimer's disease, it doesn't hit, you know, until something dramatic happens where a
Mhm.
family member discovers there's no money to pay the bills. You know, none of those markers that actually mean something,
Mhm. Mhm.
none of that has been, even in our cause and even in our population models, they're not looking at those clinical outcomes that is what patients want, right?
Mhm.
The patient or the family member, they want to not go into the nursing
Right.
home. They don't want the finances of their loved one to be, a mess. They don't want to, have these, where grandma doesn't remember, the names of the grandchildren. That's what's important to the patients. And when you think about the 4 M's of geriatrics, of what matters most, mentation, mobility, well, even microdosing, there's always issues with, especially long term, of mobility issues, which ties into the 4 M's of geriatrics, the mentation. A lot of
Mm.
these studies talk about how there seems to be less cognitive decline, but reaction times slow down. And there's a slowing down of like ability to, to complete activities.
Mhm.
That mobility piece is so important with geriatrics. And then unfortunately, the the continuing of the Alzheimer's disease, the worsening of cognitive decline, or the worsening of cognitive decline, actually mimics what lithium toxicity can look like.
Mm.
And so
Yeah.
unfortunately, you could get into this, cycle of, well, this, it looks like the symptoms are getting worse. I'm going to up the dose of the microdosing, but actually it's a sign of lithium toxicity.
Yeah.
So
Yeah.
that's, a challenge as well.
That could be very hard to tease apart. So bottom line, in terms of the evidence, we only really have these population-based observational studies that have suggested a link to generate hypotheses, but not necessarily change practice. The We also have some animal studies or in vitro studies, again, not anything that would change practice necessarily. But then we also have some small human studies, but not looking at the outcomes that matter to patients. Is that sort
Yes,
of where we are in the state of the evidence currently? Okay.
perfect.
Okay.
Perfect
Okay.
summary.
All right. So given that, if you had a patient who asked you today or their caregiver, I heard about microdosing lithium. I heard it's really great for managing Alzheimer's symptoms. Is this a valid option that I should be considering? How would you respond to that patient or caregiver?
I would talk about how it's really too early in the science to talk about using low dose lithium. I would also talk to them about how complicated lithium
Yeah.
monitoring is. It is not a simple, I'll, order this off the internet and a DIY.
Yeah.
Talking about how important monitoring levels are, and that requires frequent blood work. And when we talk about, healthcare burden,
Yeah.
you have to have the risks and the benefits. I would talk about, and I think that's something that the lay press doesn't do a great job, that we get splashy headlines. It was in 27 people. It was in
Yeah.
mice. It was in
Right.
cell
Right.
cultures.
Right.
Um, that being said, that the evidence is still preliminary, and
Hmm.
that a lot of this preliminary data maybe in the future. Maybe in
Hmm.
the future we'll see some benefit, but right now it's just not ready for prime time, and especially it's not ready for, DIY
Hmm.
off the internet.
Yeah, and so we didn't even really talk about that. So you mentioned, off the edge on that. It is something. There are lithium supplements that people can buy online, and so that's maybe you could talk a little bit about that. Like, say somebody has already bought it and they come up to the counter and say, "Hey, I got this. I read about this. Is this the right product for me?" How then, say they've already sort of gone that extra step, where would you take that conversation?
Yeah, so definitely if I had a patient coming to me and it was in their, bag of medicines or dietary
Yeah,
supplements or things
yeah.
like that, I think I'm very conservative in my practice. I think I've seen way too many geriatric patients where things went horribly wrong. So I'm pretty conservative. So I think my first reaction would be contacting their primary care doctor and saying, we really need to get a blood level. Let's see, how much you're actually being exposed to.
Hmm.
Because, as pharmacists, we know that what patients find off the internet, maybe it has zero lithium in it, and maybe
Hmm.
I don't need to be concerned. Maybe it has 800,
Yeah.
milligrams of lithium in it. We don't know. So the first thing I would definitely do is I would contact their primary care physician and ask for a lithium level to see, has the patient been exposed? I would also start asking about how they're feeling. I would ask about NSAID use. I would ask about our common blood pressure medications. We didn't even get a chance to talk about, are they on any blood pressure
Hmm.
medications? Are they on any diuretics?
Hmm.
And then really talking about how if they're on diuretics, if they're on an ACE or an ARB, then I would definitely talk about, hey, the long-term risk of you becoming toxic on this, even at a microdose,
Right.
is pretty significant. And the adverse effects are not, they're not mild. I always think back of, gum recession and having like zombie mouth due to when we didn't have any other options, right? And patients just had to deal with the adverse effects for medications that, treated bipolar or schizophrenia.
Hmm.
We have so much better options. They don't have to do that.
Hmm. Hmm.
Now, if a patient came to me and they were on lithium, and maybe they were having compliance issues and they were having bipolar episodes that were damaging to their health or their financial well-being. Maybe I would use that as a little bit of carrot if there were compliance issues that were leading to hospitalizations or, bad outcomes and say like, hey, if you take lithium for bipolar, there might be this added benefit. So I think there's two groups to approach. The group
Right.
who's
Right.
trying to DIY, and then
Right.
maybe there was some compliance issues, um, and lithium was treating effectively the bipolar.
Sure.
Use it as a carrot.
Yeah. Yeah, and I think, in my mind, I'm really thinking about the people who have heard about this microdosing concept and have wanted to try it over the counter. And those people, like, I think what you've made very clear in your discussion here is that even though it might be microdosing, it's over the counter, it's a supplement, it's not, something I need a prescription for. It doesn't mean it's safe. There still can be risks. And like you said, just with supplements in general, the fact that they are not regulated the same way as drugs, they might have nothing, they might have high doses, or they may have other contaminants or other ingredients that the patient may not even realize. And to your point about older adults being at higher risk for some of these issues because of polypharmacy and all these other things like that, supplements are not necessarily benign. So even though they might be thinking, oh, it's not going to not harm me, or, there's minimal risk, it's over the counter, there still can be some risks. And I think that's a really important point to drive home in some of these conversations too. And then to your point about adherence too, even outside of the potential role in bipolar for lithium, adding on a supplement in addition to the other medications they're taking is another pill to take and could impact adherence to other medications that are actually providing benefits. So I guess what would you help steer patients toward if they were looking for something to help manage their symptoms? What could we suggest instead that might be a safer or more appropriate alternative for their Alzheimer's symptoms?
Absolutely. So, if we're following the lines of lithium microdosing for neuroprotection, we actually do have interventions that have been proven to have neuroprotection, and actually do align with the programs of geriatrics. So, mobility. So, exercise has people who exercise have shown to have decreased risk of Alzheimer's disease. Once again, population models, very similar to the, observational studies. But what's the downside, right? What's the downside of exercising? And oftentimes when I talk to my geriatric patients about exercising, sometimes there's this whole like, well, I haven't, I'm not a runner or I don't exercise. And the benefits that we see with exercise, it's literally going for a walk, right? Just literally going for a walk. 3 times a week. And it doesn't have to be a 5K. And for weightlifting, older adult females, there's so many benefits. And it doesn't have to be, the weightlifting competition. It can literally be a mobility issue, sitting in a chair and doing, 2-pound weights or soup cans or, what you have in the home. And so we do know consistent movement, and maybe that's the better way to describe it instead of exercise.
Hmm.
Consistent movement does help prevent Alzheimer's disease. It increases balance, helps with meditation. So that's an easy answer right there. Also,
Hmm.
with a lot of gyms and community centers, it hits the social aspect, and we know that patients that are invested in their community, who are involved in things outside their home and giving to others, have lower risk of Alzheimer's disease. So, going to a community center and walking the track and chatting with people and getting outside your home and maybe getting involved in community service, all of those things have benefits across the 4 M's of geriatrics, including meditation and mobility. And there's very little downside. So
Right.
I would say, exercise, there's also learning something new, and it doesn't have to be academic. Learning a new class, learning a new hobby, taking on a new, project, learning something new also seems to help have some neural protection as well. And so once again, it hits all of those items of getting out in the community, doing something, learning something new. Uh, you know, and then if you're talking about management of symptoms for Alzheimer's disease, maybe you have a family member who is getting frustrated because, they expect the prescription medications, grandma's not better. And we don't sign from a scientific community, we don't do a good enough job talking about, hey, this is one of those disease states and medications where no change.
Right.
That's good, right?
Right.
All these medications, a California stop sign, they're just going to slowly roll through Alzheimer's and help slow that down. But music therapy for agitation, for combativeness, have actually shown to do a better job with less side effects versus the psychotics.
Wow.
And
Yeah.
facility. And so there's lots of non-medication options, whether it's treating symptoms or neuroprotection, that have lots of benefits and none of the risks that come with, lithium.
I think, it's always hard, as you say. I think recognizing and empathizing with the patient or their caregiver about the challenges with this condition, as you say, it's not well publicized that, any treatments that you might get are not expected to reverse it. You're not, it's about slowing down the progression if the symptoms are going to be managed. And also that, there are limitations with the drugs that we have and recognizing that and some of those non-pharmacological options like the activity and social, and, things like music therapy or, I think I've seen about like animal therapy too,
Yes.
animal,
Yeah.
yeah, just some of these things that it's a very difficult condition to manage, but there are some things that we can offer instead that might not, that you say are low risk and can have benefits. So I think that's a great message to end this discussion with, that there are other options available. And so maybe Dawn, as we wrap up, this is our Game Changers Clinical Conversations podcast. So what is the game changer that you would take away and want people to leave with from our discussion today?
Microdosing lithium is not a game changer. I think we talk to our patients about the limitations of the medication. We can talk about how there are safer options for our patients, and that microdosing lithium, whether it's prescription or DIY, is just not ready for prime time.
Not ready for prime time. Promising does not equal proven, right? It's keeping that in perspective. Fantastic. Well, thank you so much, Dawn. Really appreciate your time. And this conversation has been super interesting. And I just think lots of practical pearls to walk away with. So thank you so much.
Excellent. Thank you.